This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Alexander Menze. I'm with the Permanente Medical Group in Sacramento, California. Today, I'm interviewing Christopher Klein with the Department of Neurology at Mayo Clinic, Rochester, Minnesota. We will be discussing a paper published in Neurology titled GLP-1RA Associated Diabetic Lumbosacral Radiculoplexus and Common Fibular Neuropathies. Good afternoon, Christopher. Thank you for joining us today.
Thank you, Alex.
Christopher, you and your co-researchers on this paper found that GLP-1s, drugs that are on everyone's minds these days, are associated with a severe, painful peripheral neuropathic disease process called Diabetic Lumbosacral Radiculoplexus Neuropathy, also known as diabetic amyotrophy, in addition to another neuropathy called common fibular neuropathy. In a few sentences, tell our audience how serious this situation is for diabetic patients on GLP-1s.
Well, Alex, it is a very serious concern, though I want to frame it carefully. So on the one hand, the GLP receptor agonists are transformative therapies. They improve glycemic control, drive sustained weight loss, and lower cardiovascular risks. And the number of clinical trials have now shown they reduce stroke risk, heart attacks, and even causal mortality. So for most people with type 2 diabetes or obesities, these are the best therapies we've ever had. But on the other hand, our study shows in a subset of patients, these drugs are associated with some of the worst disabling neuropathic syndromes, diabetic amyotrophy and common fibular neuropathy. These are not slow, insidious, link-dependent sensory neuropathies. In fact, they're typically rapid onset, painful, and disabling. So in our series, 2/3 of the patients with the diabetic amyotrophy lost ambulation and needed walkers or wheelchairs, and recovery was very slow and incomplete. And they were mostly left with persistent pain during the study period. So in the common fibular neuropathies, it was less dramatic, but half of the patients, a little bit more than half, required ankle-foot orthotics, and this definitely affected their ambulation. In terms of an absolute risk, the rise was quite striking during our study period. So since the onset of the use of FDA-approved GLPs, we saw in the last 5 years a 700 to 900% increase in these neuropathies. This parallels the increasing and explosive rate of GLP prescription. So one of the take-home points is that the benefits are high, but we need to recognize, monitor, and mitigate these risks in certain patients.
7 to 9-fold increase sounds like an awful lot. And could you tell us a little bit about what that means in absolute numbers across the nation?
So what our study can't do, because it's a retrospective nested case control study, is tell us about incidence and prevalence, because it's not a population-based study. And so those studies are definitely needed, and they will be the gold standard for knowing about the risk of these drugs. But we did do an odds ratio for an exposure rate. So if you take one of these drugs, you have about a 50% greater risk to develop DLRPN and about 30% greater risk for fibular neuropathy. In a population of 100,000, that might increase the numbers from a handful to a little bit more than a handful in both groups. So they're both pretty rare conditions, but they're significantly increased with these drugs.
Let's go to basics. Tell us a little bit about how these patients present and what they're experiencing, Chris.
Yeah, so this disorder's been around forever. Originally, it was coined Bruns-Garland syndrome, and then diabetic amyotrophy, which highlights the amount of weight loss and muscle atrophy these patients develop. And then more recently, my colleague Jim Dick coined this term diabetic lumbosacral radiculoplexus neuropathy. And it's a good term because it helps you to understand what all is localization. So generally, it's occurring in typically diabetics who do not have end-organ complications like retinopathy or nephropathy. They tend to be milder diabetics, and it starts suddenly with severe pain, generally in the hip, thigh, or buttock. And they often cannot sleep, and most describe it as some of the worst pain of their life. And as the pain continues, they develop weaknesses of the thigh muscle, and typically the quadriceps will become atrophied. And you can see the atrophy if you just pull the pant leg up, it's pretty prominent. And a lot of these patients get referred to spine surgeons and orthopedic doctors for hip and back issues. So recognizing that phenotype's important. And then as the one leg is improving, it may jump over in about 50% of patients to the other leg. So that's what often leads to the loss of ambulation. And that loss of ambulation in our study was 2/3 of patients. But in earlier studies, not GLP, it was about 1/3 to 50% of patients. And so it's an axonal process. The EMG shows that. And then many patients have a very prolonged recovery rate, of which most will regain ambulation, but it can be a couple years before they do, and with pain persisting throughout that period. So that kind of gives you a sense of it.
Yeah, it certainly does. Now, I don't want to get too off track of where we're going with the GLP-1s and this association, but I also want to ask you, since we have you here, can this happen in non-diabetics, or do we call it something else when it happens in non-diabetics?
Yeah, you just knock off the D on DLRPN, so it's LRPN, and it's about 8 times less common among non-diabetics. And it's interesting, if you follow those non-diabetics, some of them are glucose impaired, but if you exclude those, it still can happen in non-diabetics, but it's fairly rare.
And then if we go a little bit higher and we talk about the Parsonage-Turner syndrome and stuff, is this all kind of related in your mind, pathogenesis-wise, or how do you see that tying in?
So the nerve biopsies are fairly similar, and they tend to be consistent with a non-systemic small vessel vasculitis. So there is that similarity, but less than 10% of Parsonage-Turner patients will develop involvements of the thigh. So there are some similarities, including the early atrophy, which is very helpful as clinicians to recognize, because that very greatly limits the differential diagnosis for you.
Chris, are the GLP-1s directly damaging the peripheral nervous system? Do you think that it's like a direct causal thing?
Many of the benefits that we see from GLP-1s relate to their expression in neural tissues, including the brain, where it can suppress appetite. But we do know that they are expressed in not only the nerves at the DRG and autonomic nervous system portions, but also in the microvessels. And so we don't think it's directly toxic to nerves. Rather, we think it's an avascular ischemic mechanism. So in the biopsies of our patients, we saw the typical pathology that has been described in DLRPN, which is microvasculitis. But it was more common in our patients comparing to the earlier pre-GLP-1 drugs. And the trigger, we think, is a rapid metabolic shift. So big drops in A1Cs trigger this catabolic event that's associated with inflammation. Now, whether the inflammation is actually reactionary or causal, that remains a big debate. So the inflammation is important, but it may not be the entire story.
So, Chris, we have a lot of neurologists who practice in areas of the country that maybe don't have access to extraordinary nerve conduction study capabilities, and they do the basic stuff, and they certainly don't have access to getting an easy biopsy of the plexus or these nerves and everything. So could you tell us a little bit how you'd recommend that somebody go about doing this, and maybe in a rural setting, or talking to patients about this, or evaluating them, or making the diagnosis clinically? Do you have any recommendations there?
It is a big challenge. And one of the reasons it's a challenge, it was a challenge for us when we did the retrospective chart review, is there's a social phobia about using medications for weight loss. It was often not well recorded in their charts, and we used a number of different approaches to get a comprehensive summary. So the first question is just to ask if you're suspicious of diabetic amyotrophy or a fibular neuropathy, whether patients are using these drugs. And so that's the first part. And of course, recognizing both neuropathies, we just rely on our good localization skills. And for at least for the DLRMP patients, it's really important to see that atrophy. And another really helpful clinical pearl is touch hypersensitivity, which you don't tend to get with any of the other mimickers of this. So a lot of these patients will develop in the thigh hypersensitivity, where they don't want to have anything touch it on the sheets at night, or a light stroke just rubbing up against something, things like that.
That's really helpful. So let's just do a quick case that may come across somebody. So somebody comes in, they have this buttock pain. Of course, they've been initially evaluated. Maybe it's sciatica, and then all of a sudden they're just screaming in pain, and they've got the touch hypersensitivity, and maybe they're starting to get weak in the thigh. What's a neurologist to do? Do you think that we should be getting baseline MRIs, like of the plexus or of the lumbar region? Should that be a standard in these cases to rule out other things? What do you think?
Those features you mentioned are helpful. Other things that can help is that the males, about 50%, will develop erectile dysfunction, and almost 2/3 will have autonomic instability, so they'll get lightheadedness. And a very important feature, which kind of ties in with the GLPs, is that even independent of these drugs, they'll have lost a lot of weight. So, the kind of average is 20 to 40 pounds people lose. And so if you have all that, your index of suspicion for a structural process is significantly reduced. However, there is one exception, which is where imaging is very important, is lymphoma can do all of this. So we generally do image either the back or the thigh to make sure there's not an infiltrative process, and just with caution, because sometimes a disc is found and that is sort of the stick and lock nest that becomes Nessie. You don't want to be sending these patients to back surgery if you have all the above things I mentioned, because it's likely to make them even worse, because we've noticed surgery will actually induce an increased activity of this condition. So that it is a clinical diagnosis, tests can be helpful.
This is like gold to the clinical neurologist. I really appreciate you going through this, Chris, because these are questions that have come up in my career multiple times. Weight loss, maybe A1C change, touch hypersensitivity, erectile dysfunction, severe pain followed by atrophy. Those are all key clinical concepts when trying to accurately diagnose DLRPN. And I really appreciate getting to talk to you today. This is great.
My pleasure.
We already talked a bit about who's at risk for getting this. I'm going to jump a bit and ask if there's any genetic link or genetic causes that anybody can look at that may be associated with this. What do you think there?
So it's probably polygenic, because we have recognized, this is, again, earlier work from my colleagues, Jim Dick and Marcus Pinto here, who've done a lot of epidemiology of this disorder, is that there's a couple comorbidities. They're not pathognomonic, but coexisting autoimmune conditions like rheumatoid arthritis, lupus, mixed connective tissue disease are more common in these patients, as are histories of ischemic stroke. So unfortunately, in our series with the DLRPN, it was a vast minority that had those. So it's hard, and we don't have a good biomarker to predict these patients, but we're pretty good at knowing that dramatic shifts in HbA1c, weight loss, are pretty good triggers. So that's probably the most easy to recognize as in terms of it actually happening.
So there are a couple similar conditions to DLRPN that we sometimes run across in neurology. One of the worst types of neuropathy that I have seen is treatment-induced neuropathy and diabetes, TIND, which just seems to be totally catastrophic for patients. Can you talk a bit about this, about its similarities with DLRPN and what these types of patients look like, and if there's any studies going on that may link P1s to TIND as well?
Yeah, I think the treatment-induced diabetic neuropathies, which used to be called insulin neuritis, because there was this link between the initiation of insulin and these catastrophic attacks, they parallel what we're describing here very similarly, with some exceptions. They often occur within weeks of the drug's initiation. So once patients were put on the drugs for GLP drugs, they frequently had their attacks fairly quickly to the onsets, just like with insulin or other diabetic treatments. They also have excruciating pain. They tend to be more diffuse, and for the earlier ones described by Chris Gibbons at Harvard and others, they tend to have a lot of small fiber, and that's probably where the pain originates from. They also develop autonomic dysfunction, including gastroparesis, sexual dysfunction. And they have similar pathology among the rare cases that have been biopsied. So they also have a microvasculitis. There's a lot of overlap. And in fact, this GLP-1 treatment-induced syndrome is probably under the same umbrella.
Prognosis-wise, is there any distinction between TIND and DLRPN?
So one thing I do want to emphasize is among the patients in our study, there was a higher rate of wheelchair dependence. And then we saw earlier, either with just other treatment-induced neuropathies or in the classic diabetic amyotrophy predating these drugs. And why that is, we're not entirely certain. We saw higher rates of microvasculitis, so whether the vasculitis is more dramatic. Another possibility, which is important across the whole spectrum of neuromuscular disease with GLPs, is that we know that when patients start these drugs and they're succeeding and they're losing their weight, they lose about 30% of their lean muscle mass. So maybe the reason these patients are worse is they've lost lean muscle mass, plus they have this syndrome. And so they can't compensate with what other muscles that are not historically affected by the microvasculitis. And that actually we've seen, and we didn't address it in this paper, but we've seen that in other neuromuscular diseases where patients are put on these drugs and sometimes they get taken off of because they just feel so much weaker. And that gets to some of the things we can do to help treat patients who begin these drugs and how we need to be aware of them as neurologists.
Let's shift gears a little bit to common fibular neuropathy. I call it perineal neuropathy, but there's two different names for it. But the textbooks talk about how people might be damaging the nerve at the fibular head, right? So by crossing their legs or leaning their leg against something, I always say when all else fails, blame the patient. But are you buying that as the cause of common fibular neuropathy? Because when I look at nerve conduction studies, I'm not seeing like a huge block right there at the fibular head a lot of times. And so could you just talk a little bit about that clinically? Because I've abandoned blaming the patient or telling them that they're crossing their legs too much.
Some of the earlier work from Asa Wilburn did a really nice job, including some pathologic studies to actually identify that it is at the fibular head. But like you said, many patients, they don't remember the event. And that is often not because they didn't do it, but because it's often painless. And in our study, we did find blocks at the knee, and we always study the short head of biceps femoris. So we know that it's not, a more diffuse proximal, either back or other process. So I do think it's at the knee, but your question about the compression is a good one. Many of our patients in our study woke up with it. Unless they're sleeping on a board, it's hard to understand how a mattress alone might do this. We did not have, unfortunately, a single case where the fibular sensory or perineal sensory branch was biopsied. And I think that will be important to do because maybe these are a much more limited microvasculitis that's painless. And that's another thing. There is an even rarer condition that is a painless diabetic lumbosacral radiculoplexus neuropathy. And they have the exact same pathology. They develop all the other problems, but they tend not to have pain. And we have no idea why that is. And their natural histories are very similar to the painful diabetic amyotrophy. So lots to do yet in trying to understand this. We did see in our study, though, that weight loss was more important than A1C correction in the fibular neuropathies. So that would lay credence to the idea that you're losing some kind of fat pad around your knee. In whole, I do still believe it is compressive. To be continued, there's more work to be done.
I'm just going to call the common fibular nerve a bad design because if I see a patient come in with a widespread sensory motor peripheral neuropathy that's length dependent and diabetic and progressing over years, they're going to have foot drop and they're not going to have tibial neuropathy type symptoms as much. That's what I see clinically. I don't know if you totally disagree with me. I would love it if you would, because that would help me out. But I don't know what you think there.
I think that a diffuse neuropathy is a risk factor for this. Unhealthy nerves are more susceptible to compressive injury. And so it gets more complicated when they have other findings. And of course, don't forget, a very common condition, often overlooked, is hereditary neuropathy with pressure palsy. And those patients, almost all of them will have developed a fibular neuropathy at some point during their lifetime. And most of them have a superimposed polyneuropathy. This just expands our differential and keeps us thinking as neurologists.
Christopher, are the numbers of people getting these types of neuropathies great enough that we need to get aggressive with directing physicians to be judicious with slowing down weight loss in certain types of cases or not lowering the A1C too quickly? People start losing weight in diabetes and they're just so happy, especially if it comes out quickly. Should we be telling people, whoa, you need to really slow down with this stuff?
That's one of the questions we're raising and have been working with our endocrinologists here at Mayo and our community neurology practice, people who see these more common than I do in a subspecialty clinic. The first thing we need to talk to and internists need to talk to is give patients an awareness of these risks. And maybe, let's say there is a compressive risk, by just talking to patients about that risk, we can reduce the occurrences. Given the uncertainties that we talked about, I still think it's important to remind patients that they are at greater risk for compression injuries with weight loss, just like we do with our chemo patients or our cancer patients. So that's one thing that can be helpful. Now, in terms of the rate of weight loss, I think that what we saw that our patients lost weight at a greater rate than most patients on these drugs. So now whether that's the induction of the catabolic state and it's not the drugs per se is really unanswered. And we raise the question whether if you have a diabetic who has vascular risk factors, maybe even an earlier stroke, and maybe coexisting autoimmunities, a lot of things we know that are associated with DLRP attacks, would it not be wiser to use some of the older drugs like the liraglutide that don't make patients lose as much weight as quickly? But we need help from the American Diabetes Association and the medicine community at large to understand this. As you pointed out earlier, we really don't have a good biomarker to predict who's going to get these. And another thing to emphasize is even though 90 or so % who had the diabetic amyotrophy stopped the drugs, many or most patients after their attacks resumed them because they were so effective for managing their sugar and their obesity. These are very important questions, need everybody pulling the rope the same direction. But for right now, it'd be reasonable to say, look, you have this risk. You probably shouldn't lose more than a pound a week. And you probably shouldn't lose more than the goal of 14% over a period of 4 months. So those are already standard guidelines. And if you start doing that, you probably should let your doctor know. And I think patients need follow-up on these drugs to make sure that they aren't entering into this and that maybe we can even abort an early attack. So lots to be done.
Yeah, that just brings up so many issues in our society with access to these medications. You can go to other countries and buy it straight out of the pharmacy or go online and get it without having any doctor-patient relationship. So this is out there. Patients are taking it left and right, and an 8 to 9-fold increase in the numbers of these neuropathies, the DLRPNs, over your study period is fascinating. It's incredible that you're here teaching us about this today. So, Christopher, can you give us a last summary of what we've learned from your paper and how we can try to apply it to our everyday clinical practice?
So I think that the kind of key points I would make is inquire with your patients if they're on these medicines, because as you just mentioned, a lot of these are even being done black market. So you need to know about it so that you can inform them about the risks, especially if they're diabetics. Then the things you can do maybe prophylaxically is counsel them about compressive risk, counsel them about rate of weight loss, and then early thigh or back and buttock pain as risks, as indicators of an early diabetic amyotrophy attack. And if you do that, you've done a lot to help the situation. And a lot will follow, but those are the things we can do right now before consensus guidelines are created on a bigger scale. Because don't forget how useful these drugs are. And some diabetics are actually literally being cured. They're coming off all their other diabetic meds. And for obesity, it's been a home run. So they're here to stay. We just need to try and help awareness and prevention of these complications.
This is great information, Chris. Thank you so much for your time today and for sharing all of your knowledge with us. I've been speaking with Dr. Christopher Klein about his paper titled GLP-1RA, Associated Diabetic Lumbosacral Radiculoplexus and Common Fibular Neuropathies.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.